All right, let's jump right in. We're going to tackle a pretty serious but thankfully not super common condition, the pyogenic liver abscess. Now, what is that? Well, in simple terms, it's a pocket of pus that forms inside the liver because of a bacterial infection. We're going to break down this whole medical mystery piece by piece, from the very first clues all the way to the final treatment.
So picture this. A patient walks in. They've got a fever, this nagging pain in their belly. The symptoms are kind of vague, right? But the real culprit could be something way more serious, hiding out deep inside one of the body's most vital organs. We're going to follow the clues, just like a medical team would, to solve this thing. And listen, the stakes here are incredibly high. This is not some minor infection we're talking about. If a pyogenic liver abscess gets missed or just isn't treated, the consequences can be, well, they can be fatal. That's exactly why understanding it, spotting it fast, and hitting it hard with treatment is so critical.
All right, so where do we even start our investigation? Well, with a pretty simple question, really. Who's most at risk? You know, like any good detective, the first thing doctors do is look at the profile of who's most likely to be affected. So let's check out those risk factors. You can see the high-risk profile covers a lot of ground. I mean, things like diabetes or a weakened immune system, they basically lower the body's defenses. If you've already got liver problems, that creates a vulnerable spot. It also tends to show up more in the elderly and just a bit more in men. And here's an interesting one: the chronic use of those common acid-reducing meds, PPIs. Why? Well, the theory is that by tamping down stomach acid, it can mess with your gut bacteria, and that might just give the bad guys a chance to get a foothold. Okay, so we've got our list of usual suspects. The next big question in this mystery is, how in the world did bacteria get into a heavily protected organ like the liver in the first place? Let's trace it back to the source. So, believe it or not, the #1 pathway starts in the biliary tract. The best way to think about it is like a plumbing system in your house. If a bile duct gets blocked, say by a gallstone, it's just like a clogged drain. The bile has nowhere to go, so it backs up. And any bacteria that are trapped in there, they start multiplying like crazy. From there, the infection climbs up the ducts and eventually spills right into the liver tissue, creating that nasty pocket of pus. Yeah, the biliary tract is definitely the main highway for this infection, but it's not the only way in. Bacteria can also hitch a ride through the portal vein from other infections in the abdomen, or even spread directly from an organ that's right next door. But look at that chart. What's really wild is that huge slice of the pie. In a shocking number of cases, doctors never actually find the original source. They call these cryptogenic, which is just a fancy way of saying of hidden origin, a true mystery. So who are the actual bacterial culprits behind all this? Well, it's usually not just one bad guy. It's a mixed bag of bugs, or polymicrobial. The most common offenders you'll see are E. coli and Streptococcus. But there's one in particular that really makes doctors sit up and pay attention: Klebsiella pneumonia. This one is notorious for causing a much more aggressive, destructive disease, especially in patients who have diabetes. All right, we've got our suspects and we know how they operate. So how does the medical team actually prove its case? This is where we get into the diagnostic phase, where they start gathering the hard evidence. You know, the first clues you get from the patient can be really tricky, mostly because they're just so vague. There is a classic trio of symptoms: a fever, that general feeling of being unwell, malaise, and pain in the upper right side of the abdomen, right over the liver. But the thing is, a lot of patients don't show up with that neat little package, which can make spotting it early on a real challenge. So the next place you look for clues is the blood work. And here you'll almost always see the telltale signs of infection and inflammation: a high white blood cell count, jacked up inflammatory markers. Blood cultures can even catch the bacteria red-handed about 60% of the time. But the big clue, the one that really points a giant flashing arrow at the liver, is a sky-high level of an enzyme called alkaline phosphatase, or ALKPHOS for short. We're talking elevated in up to 90% of patients. That's a huge hint. So the blood work points a finger, but you still need to see the crime scene, right? And like the source material says, imaging is what really seals the deal. This is how you get that visual confirmation. The two main tools for the job are ultrasound and CT scans. An ultrasound is usually the quick first look. It shows the abscess as a dark little pocket, because the sound waves just pass right through the fluid inside. But a CT scan, that gives you a much more detailed picture, especially when you use a contrast dye. The pus-filled center shows up dark, but it's surrounded by this bright, glowing ring of inflamed tissue that's soaked up all the dye. And on that CT scan, what doctors are really hoping to find is this:
The double target sign. This is the classic visual. It's the bullseye that tells the team, yep, we found it. Those rings are the smoke and gun that confirms without a doubt that they're looking at a liver abscess.
Okay, so the case is cracked. The diagnosis is confirmed. Now it's time to fight back. And the treatment plan is an aggressive two-pronged attack. The strategy really has two core parts, and they absolutely have to work together. First up, you hit them with powerful IV antibiotics, and you start them immediately to go after the bacteria all through the body. And it's a long course, we're talking 4 to 6 weeks. But second, and this is key, for any abscess that's bigger than a few centimeters, you have to physically drain the pus out. See, antibiotics alone just can't get into that dense pocket of infection well enough to do the job.
The drainage itself is a really precise procedure. Using an ultrasound or a CT scan to guide them, doctors insert a skinny little tube, a catheter, right into the abscess. The pus gets strained out, and they flush the catheter regularly to make sure it doesn't get clogged. That drain stays in place until the output slows to just a trickle, and, just as importantly, the patient's infection markers in their blood start coming back down to normal. So, with the infection finally under attack, we can start to look at the aftermath. What are the potential dangers that could still pop up? And what does the long-term outlook really depend on? Yeah, even with treatment underway, you're not totally out of the woods. The infection can spread into the bloodstream, triggering sepsis, which is a massive body-wide inflammation. It can also irritate the diaphragm and lungs right above it, leading to pneumonia. And the absolute worst-case scenario? The abscess can actually rupture, spilling all that infectious pus into the abdomen or chest. That is a full-blown surgical emergency.
Ultimately, how well someone recovers really comes down to a few key things. The prognosis tends to be tougher for patients who are older, have a compromised immune system, or are dealing with multiple abscesses instead of just a single one. And if a patient needs open surgery instead of a simple needle drain, that's usually a sign that it's a much more complicated case.
But here's the crucial point. Despite all the really serious risks and potential complications we've just talked about, this is a solvable problem. With a quick diagnosis and that modern two-pronged attack of antibiotics and drainage, the vast majority of patients survive and go on to make a full recovery.
So there you have it. A pyogenic liver abscess, something that used to be highly fatal, is now a medical mystery we know how to solve with the tools we have today. It really makes you wonder, doesn't it? What other medical puzzles are out there right now that we're just one clue, one new piece of technology away from solving completely?